Hi, everybody, and welcome to this edition of the Dr. Darrow podcast. Today, we have with us Dr. Jill Davis. Yes, I know if you're in hearing healthcare, you know exactly who Dr. Jill is. But today, I want to dive a little bit deeper to learn a little bit more about Dr. Davis, sort of how she came about, what's the whole deal with musical therapy and cognitive therapy, and how we can really do so much more as hearing healthcare providers. So Dr. Jill Davis, welcome to the show.
Thanks for having me. I appreciate it.
No, absolutely. And this has been in the works for a long time. We've been talking about it, but I'm just glad that we finally sort of nailed down our schedules and got you on. So I guess I want to start with, tell us a little bit about your story, about your why. I mean, most audiologists, most hearing healthcare specialists don't go the route of owning a private practice, consulting with, healthcare organizations. So tell us a little bit of your story.
Yeah, for the majority of my career, I worked in ear, nose, and throat clinics. So I was bouncing around a few of those as I was raising a family, having babies, and that was a good setup for me. I could leave my work at work and go home to the family. And something clicked along the way when I was at my last ENT office, where I was getting the comment a lot where patients would say, "Why hasn't anyone done this before?" And I wasn't doing anything that I felt was different. Sometimes they don't remember the test that they had somewhere else. Sometimes, you just kind of take it and say, "Well, you're here now." But more and more, they were sending their friends. They were coming to the office and they were like, why have I not been told this? Why have I not done this test before? And I was just doing what I was trained to do. Most of my career I spent by myself as the single provider in that office. And so I didn't really know what else was going on in other audiology clinics. But I think a lot of it is just best practices, but also educating the patient, like really letting them understand like what we're doing and why I'm doing what I'm doing. And when a patient tells you over and over, like, why is it different here? Like, what's different here? It gives you more motivation to be different and do more things. And so the biggest part of that, I think, is just staying educated and looking in the industry, looking outside the industry, like seeing what's going on and staying up to date. And so then I can better serve my patients. So it's all about, I want anyone that comes to my clinic to have the best possible care, and staying up to date with the literature is one way to do that. However, when I was presented with the chance to purchase a practice in Austin, it was something that was kind of in my mind that I wanted to be a business owner, but it was the right time, right place, the point in my family. It just made sense. And what I wasn't expecting was the creativity that comes along with being a practice owner. Something about maybe when it's your own business that you have the chance to take risks and you can do more things and you can go by what's right for the patient. And so, I would be going into work and it's a 45-minute drive to my clinic, and just the ideas that were coming up and the things that would spark from just being excited to get there to help work with patients, it's really kind of snowballed this, working with Cognivue, doing the cognitive hearing science, creating a brain training program, like all of the things that it's like, how do I fix the issues that the patients are going through? I'm motivated to help them. So I think I need to get better, and it all works out.
I mean, that's a really cool story that even I really didn't know how you sort of stumbled into this. I was taking some notes because that was a lot. There's a lot to unpack there. And I want to start with one of the first things you said, which is the patient who comes in and says, wait, this is different. And to you, right, you're doing best practices. You're doing what you were taught, whether it be a cognitive screening, whether it be Really, or whether it be speech and noise testing. So you're doing what you're supposed to do, which is one of those crazy things about hearing healthcare. And I think it's part of the reason why there's a lot of controversy and a lot of issue in our field, is because we're almost not forced to practice to the full scope of our license. We're almost not in a position where we're held accountable to actually follow through with best practices. And so when a patient says, this is different from somewhere else, fine. Maybe some don't remember. But I really believe that's because the vast majority are minimizing their value and just doing airborne speech. And then here's airborne speech. You need a hearing aid. What do you think? Which is wildly different than what hearing healthcare is supposed to be.
Mm-hmm. Absolutely.
What has always motivated you to do more, though? I mean, I like what you said, which is you didn't realize that other people were taking shortcuts because you were living in your own bubble. But now that you're out there preaching about best practices, I've heard you preach from stage, which you're an amazing presenter. I mean, what is that like to realize that, and how motivating has it been to help other providers?
It was when a patient would have a question and I didn't know how to answer it. Um, I needed to know the answer. And when you work
Mhm.
by yourself, you look to the literature, you look to other professionals, you look to people who have done that before. And so that was my driving force, is just to know how best to work with these patients. And what happened was the word was getting out about the hearing loss and cognitive decline. And
Mm.
when patients are coming in asking you about that, I wanted to have the answer, the correct answer. I wanted to be able to talk to them about it. And what I found out is the more that we were talking about it, the more it was on everyone's mind. Like all of these patients were feeling it and thinking of it. And if they didn't bring it up and I did, it hit home with them. And they said, aha, it is more than just a hearing aid. More is going on with me than just I can't hear my spouse in the other room. And so when I work with other audiologists, it's sometimes the hardest part is getting away from the widget. We're all like trained to blame the hearing aid for these problems that the patients are hearing. And we think that adjustments and programming is going to be the best way to address those issues. Like we just look at what we can do with the hearing aid to help their complaints. But where the cognitive screening has come in is to just kind of solidify what the patient is feeling, whether it is or isn't changes in the brain that are causing their problems. And then once you know that answer, how best to help the patient. Is it strictly hearing aid and we can make adjustments, or is there more going on that we need to educate them on next steps for something else?
So I'm sure half the audience is amazed, the other half is offended by the fact that, well, what do you mean? Can't we just make adjustments and we'll do really, and we'll do this? And, somebody said this to me a long time ago, like, and this was a person who owns hearing healthcare practices, but is not an audiologist, is not an HIS by training. So I think it gave him a different perspective. He said, Keith, I don't understand why my providers always say I need to make adjustments to the hearing aids when a patient says X or Y. The hearing aid didn't change. The computer chip didn't change. The settings don't fall out. They don't decrease over time. What is that about? And I said, well, that's the cognitive changes. See, what's happening is there are changes at the level of the brain that we are not accounting for. And this was years ago where we didn't have a metric. So I love what you preach, which is like the results of a cognitive screening. While it may be intended to say, is this person or isn't this person at increased risk for cognitive decline and dementia? There's also a lot of power behind incorporating the results into your rehabilitation program. So can you give like a specific example? Obviously not patient names, but I love hearing you talk from stage about how, the patient who can't get the hearing aid in and out of their ear, if you look at visual spatial memory, it probably stinks. And so those two correlate, right? So talk more about that.
I have two that I just saw
Okay.
today, actually, opposites of each other. One came in, I haven't seen her since March of last year, and complaining that her hearing is getting worse. She's really struggling at work, which she controls 15 4-year-olds in a classroom.
Whoa.
I would not want to be that.
No.
But, but she feels like she's really struggling. She's exhausted. She can't hear as well. She didn't hear the fire alarm because she's so focused on the screaming. Like lots going on here, and also hasn't had a full, checkup of the devices in a while. And so we go through the testing. Her hearing hasn't changed. We look at the Cognivue, hasn't changed within normal limits. Everything cognitively is great. We look at the hearing aids. They're not being maintained the way that they're supposed to.
Mm.
So with her, it was a conversation of, let's get you in to see me sooner than a year. Let me show you again how to take care of your devices. Like for her, I am confident that it was just a hearing aid issue.
Sure.
And so that's the one that I can manipulate. Now, the other guy coming in saying that his whole family is complaining that he's not responding, he can't hear in background noise, his hearing has really changed. His hearing has not changed on the audiogram. His Cognivue went from normal to from the 80s to the 50s. He had a different medication for his cholesterol. He had gone through some heart stuff since I saw him last. And so with him, it was a different conversation of, I've checked your hearing aids. They look great. Your hearing has not changed. It's not the ears that are causing the problem. Something is getting in the way of your performance. So we need to talk to your doctor about this, because the good news is that I've treated your hearing. Your ears look great. Let's keep wearing the devices, but it looks like something else could be causing your problems. And it made sense to him because he's been going through all this health stuff. Like he knows that there's been a shift, and it occurred around the same time that he's blaming his ears. And as audiologists, we're like, it's got to be the ears because we're trained to work in that area, and we always blame the ears when it could be something else. And so those are very different conversations to have when you have the picture of what's going on cognitively. Is it normal or not?
So that is probably, look, I don't even know the number of episodes, but there's been a lot of these episodes. That might be one of the most valuable nuggets that I've heard on this show that I hope listeners really come to understand, which is, without using all the tools readily available, you're not properly able to diagnose. You're not properly able to set expectations, because you and I both know 99 out of 100 audiologists or hearing specialists would have just said, okay, let me do some reprogramming. Let me do some retweaking. Maybe they would do real ear. Maybe, I mean, they would probably get to a point where they would not be using science, and they would be boosting some of the high frequencies, doing all this, like making all sorts of changes.
Trial and error.
What's that?
Trial and error.
Exactly. Trial and error, right? We're using our gut. We're not using evidence-based practice, wherein you saw very clearly, because you used every tool available. So there's nothing special about, Dr. Jill Davis. She doesn't have special access to a cognitive screener. We all have the ability to do it, but you saw it was black and white. Something else is wrong. And so now, right, your patient doesn't go home and continue to complain about his hearing aids, doesn't tell, because we know what happens, right? You try to retweak, it still sounds like crap to the person. It's not working. They tell their friends, they tell their family. We have another unsatisfied patient who really poisons the well, when in fact it had nothing to do with us. It had nothing to do with that patient's hearing, had nothing to do with the widget. And now your patient is like, okay, you have done everything you can, but there's something else happening. And the rest of us wouldn't have known it.
Yep.
Which is just wild, right? I mean, how are we actually holding the welfare of each patient paramount if we're not doing everything we can? That's a rhetorical question.
Well, and there's still more we can do for those folks that we detect it may not be the ears causing the problem. That's where auditory training, listening exercises, like they are struggling. And even if it's not the ears, like I need to help this person better perform in these challenging environments. Like I am a listening specialist, so I am going to recommend not only just wear your hearing aids, but let's help the brain make sense of what the ears are hearing too. And
you just said something that we cannot brush over. I'm sorry to interrupt, but we all think we're hearing specialists. And you just clearly defined yourself as being a listening specialist. So tell me what that means. I know we've both been in talks with Doug Beck and listened to him, but tell the people listening what that means, because we're really not just hearing specialists. The art of hearing is actually requires very minimal cognitive and neural activity, but listening is wildly different.
Yeah, our ability to process sound and understand language and hear when things are challenging. The patients coming into our clinic, they all have listening difficulties. Not all of them have hearing loss. So when someone's coming in and they complain of difficulty hearing in background noise, like I had two back-to-back on Monday that were in their 40s, completely normal on the audiogram, which in my book, 0 is pretty normal, and complaining of difficulty in noise, and they were in the right place. Come to an audiologist, let's rule out the ears. However, when we don't find something with the ears, now we have to look beyond and see what else could be getting in the way. So we do speech and noise testing to see how well they do when things get challenging, and we do the cognitive screening to understand the score. Is it the ears or the brain? And so when someone comes in and it's normal hearing, now we look at what's causing their listening difficulty because of their breakdown in background noise. And so a lot of times it's in the brain. Most of the times I would say it's not the ears. And so that's when we recommend further testing, but also give them tools, not just say your hearing's normal, you're good to go, I'll see you back in a year if it gets worse. Because maybe it is coming from attention deficit disorder. Maybe it is coming from their 6 different medications that they're on for anxiety and depression. Maybe it's coming from something else that's presenting like difficulty hearing and background noise, because there's a lot of things that look like hearing loss that have nothing to do with the ears. And so even if it is, and I'm going to recommend they go back to their doctor and talk about, the results. But in the meantime, let me give you some exercises you can do to hear better in background noise. Let's help your brain filter and focus. And that's where I turn to music. I also turn to app-based auditory training, but they leave hopeful that there's something that they can do rather than defeated saying, I thought I had a hearing loss and I don't, now what do I do? And so we come up with a plan of ways that I can hopefully ease the load, make things easier, decrease that listening.
So let's talk about this, right? Because by the way, I don't even know that you realize, because this is something that you do naturally. You do it every day. There's 2 words you said earlier, which is taking risks, right? What you do is different. When you do things differently, you are taking a risk. You are the 1 in 1,000 hearing healthcare providers who says to a 40-year-old with normal hearing, there's still something we can do, because the other 999 just say, sorry, your hearing's normal. Everything's great. Good luck. And I love what you said, which is come back again next year. Maybe it'll be bad enough. It's like, let's wait for the cancer to spread before we actually do anything about it. I know, that's extreme, but you get the point. So this is really, you're taking a risk, but there's evidence behind what you're doing, right? I mean, I know you're not just going on your gut. You're not just sort of winging it and throwing music out there. So I want to learn more about the science behind music therapy, behind your listening exercises. What are some of the details there?
Yeah, I was inspired by Nina Krause's research, mainly out of Northwestern, her Brain Volts lab, where she was comparing musicians to non-musicians and looking at the brains and finding that folks with music training did better on background noise testing. They actually had less cognitive load. The listening effort was decreased, more neural connections. Things were just easier for people who play an instrument. And the same time I was looking into that was when I heard Dr. Anu Sharma present her cortical reorganization studies. That was back in 2016. And I was reading a book called This Is Your Brain on Music, Daniel Levitin. And only because I work with the brain, I like music. Let's see what he has to talk about. And it just clicked that the brain changes with untreated hearing loss. Music stimulates every part of the brain. People who play an instrument hear better in background noise. So our patients should be playing music, or ones that don't have music experience. If I can get their brain to perform better in background noise by just playing an instrument, there is no doubt I'm going to recommend that to everyone. And what I was having a hard time, and why I was even looking for this program, is because we knew auditory training helped. There is evidence to show that patients can do exercises and listen and do auditory training to improve their performance in noise, but my adoption rates were so low for those programs. I knew it would help them. I would recommend it. I would find patients who were just still struggling and they would like the idea, but they just would do it. And so by 2018, I was on maternity leave and I finally wrapped up all the music stuff and I launched what I called the Victory Brain Training Program, because that was where I looked at what protocol would work best based on the evidence and all of those neuromusical researchers. There were certain protocols that they came up with for these adults, young adults, and even old adults to go through playing piano or joining a choir, doing some sort of musical activity, and they would test their speech and noise ability and their cognitive function before the training, and then they would do it after. All of them improved in just 3 months of training. They all got better in those two different avenues. And so that's when I started offering a program to the patients where if they were struggling in noise, they could rent a keyboard from me. I had an app that they would play 3 days a week for 3 months, and we would test them Cognivue, speech and noise, pre and post to see the improvements. Luckily, 2020 happened. I mean, luckily, but people were looking for things to do. They had more time on their hands. They could start a new hobby. And so that's when I launched the exercises for anyone in my clinic that wanted to join. And we got a lot of good data from that where we could track them and see. And even the ones that thought it was tricky and it was harder to learn an instrument, they stuck with it. They were excited. Like a lot of people have pianos sitting in their house collecting dust that they haven't used. And so this was like a reason to start because I could educate them on where we see the benefits. So
I hope everybody listening realizes, because I had the flashback. I just had the flashback of my psychoacoustics course in the late 90s. I won't get into details, so you know my age. But we all learned this a very long time ago. And this is one of those things that I feel like I fault the education system. It's part of my gripe with the AUD and audiology programs is that we get a psychoacoustics class that tells us clear as day, those with musical training are better at listening tasks. But then that's it. We're told it as like a fact. We're not actually ever taught. Hey, at least I wasn't. So maybe I shouldn't speak for everybody. I've yet to meet anybody else who was taught. Now that we know this, how do we incorporate this into clinical audiology, right? We look at psychoacoustics as this tiny little field within hearing science, when in fact, what we learn in our program, you have just been the unicorn who has said, I'm going to actually take that science and that data and I'm going to incorporate it into my rehabilitation program, which is just awesome. And you have pre and post measurements. You have actual evidence-based data, not gut instinct, that actually says this works.
Yeah, that's one of the things about the literature is once I read something, I want to know how do I implement it? Like, how do I start talking to patients about it? How can I make this work for me? Because just reading about it isn't enough. Like if it's going to help people, I want to do it.
Exactly. I without even, without having been there with you, I know that in 2011, 2012, 2013, that you, like me, were already like, well, hey, there's data out there about the links of hearing loss and cognitive decline. I have to talk to my patients about it, right? Whereas, let's just say the rest of the field was sitting around arguing, is this in scope of practice or not, right? I'm pretty sure that you also believe we must hold the welfare of each patient paramount. And that's it, right? What does that mean? That means using every tool available. That means presenting your patients with science, with literature, and being cutting edge.
Mm-hmm. Well, and I have a clear picture of who is a great candidate for auditory training by looking beyond just the pure tones and the speech and quiet. When we can know for sure, is it ear or brain that's creating these listening difficulties? If it's the ear because they passed the cognitive screening, those are the patients that don't follow through with the auditory training programs. That's why there's low adoption, because maybe it wasn't an appropriate referral. But the ones that don't pass the cognitive screening, that are still struggling in noise, even after I've treated them with hearing devices, clearly there's more we need to do. And that's when you're a great candidate for auditory training. And music is fun.
So do me a favor. I want bullet points. what is the criteria? Because I think that that's really important, because you might get some people out there listening who are very adaptable. We call them these really high green bars. They take an idea and they run with it. They don't even know where they're running, but they run with it. And they say, okay, let's do music therapy starting Monday and let's do it for everybody. But that's not the case. What is sort of that bullet point of who is a candidate? How do you determine that?
The audiogram does not matter at all. The severity of loss, whether they have loss or not, does not matter at all. The hearing handicap inventory is the first thing that I look at.
Love it.
Aided or unaided. I want to know if there's a handicap over outside the normal limits, that patient is struggling and they need some help. And so I look at aided first. I'm going to treat their hearing loss first. If someone comes to me and they need devices, we go there first. And then we do a revisit after they've worn the devices and gotten comfortable. That's when we introduce the handicap inventory again. If they still have an elevated handicap, I'm also doing unaided and aided speech and noise testing. Because if I cannot get the aided speech and noise testing in the normal range, they're a great candidate for auditory training. Because I've done my part with real ear measurements. I know that I fit them the best way I can. I know that I've done what I can at a 70 dB presentation level on the Quixen. They should be within normal limits if I've done my job with the hearing aid. So if it's still elevated, they're a great candidate for auditory training. And if they don't pass the Cognivue on the second test, then they're also a great candidate for auditory training. So they can have one or all of those 3 points: handicap, aided speech and noise, and cognitive screening. That's who I find is a good candidate.
I love it. So black and white, right? I mean, I think that, and that's the way we have to approach it. Now, the next follow-up question, which is always a challenge, no matter what we're talking about in terms of rehab, is actual adoption and follow through, right? I mean, you already hinted at, right? It's not that easy, but you got to find the right candidate. So we define that. Now, how do you get these people to follow through? I mean, you're busy. You've got a lot of patients. How are you able to track these things? Like, what does that look like?
These patients are more motivated to hear better because we have educated them on the reason they're struggling. This is not just the ears and the hearing aids are going to fix everything. Before we even get started with technology, like, they understand the listening effort that goes into hearing loss. They understand the increased cognitive load. They feel that they are struggling, even though they've invested in the product that's supposed to help them. I've made it clear from the start that it's not just about the ears, that there's the brain involved that we need to work on as well. So by the time that both of us are really cheering for them to do better in that initial 3-month trial window, and it's not quite where we want it to be, instead of blaming the devices and saying, I'm going to return because they didn't do what they're supposed to, it's like, all right, now we have more to do. Like, I've gotten you comfortable, but we have more. And so they're motivated and they're excited to see what else we can do. But I'm also keeping their physician involved, knowing that, they're still not passing. So it's not just the ears, but we're going to go see what else could be getting in the way of their performance. But I'm giving them exercises and things to do. And so there is a higher adoption rate. And I make sure we schedule their follow-up, and I'm coaching them in between appointments, calling to check in and see how they're doing. Some of them do drop off. Life gets busy. It's tricky. But the ones that come back and they play songs that they've learned, or they've purchased music outside of the app that we recommend, that's my favorite thing in the world. It's like a little concert in the office. So.
Did you make a custom app for that? Just curious.
So I partnered with a group out of Berlin that was very excited about the research that we talked about. And when I told them what the program was, they sponsored all my patients to go through the program for free. And so the name is FlowKey. They were amazing. So
That's great. That's great. Look, Dr. Jill, thank you so much for your time today. I feel like, right, we got to stop there because we've already dropped 15 nuggets on anybody who's listening in terms of hearing versus listening, criteria or eligibility for a cognitive rehabilitation program, all the science behind music therapy. I am forever grateful that you have taken the time to come on here, educate me, right? Every time I hear you speak publicly, it's about, cognitive screenings. I felt like I got to dive so much deeper today because I'm typically in the audience like, I don't know, she doesn't want me asking questions, but all my questions are answered now. And I just feel like this is really this is just another way to continue to differentiate the hearing healthcare provider from the widget and to really increase our value, because I think that's the inflection point we're at in hearing healthcare. That is what OTCs have done, which is forced us to say, well, what value do we provide beyond the widget? And clearly, when you provide value like you do, you get to have a great life, you get to have a great practice, and you get to be completely satisfied with, the services you provide to every patient. So, congratulations and thank you for all you do.
Thank you so much. Thanks for having me. This was fun. I get really excited about this.
No, you should be. It's awesome. Thank you very much, Dr. Jill.
I'll see you later.